the Society for Vascular Surgery has initiated audiovisual interviews with the leaders and contributors of vascular surgery. This is part of an effort by SVS to develop archives to preserve the history of vascular surgery, as well as vascular surgery as a specialty. A committee was named by SVS, the History Project Work Group, with Jimmy Yao as chairman. Other members named were Norm Rich and me, Roger Gregory, with Cal Ernst as our consultant. As the workload increased, other members were added. Bill Baker, Mark Eskandari, Walt McCarthy, Bill Pierce, Melinda Kibbe, Ken Cherry, and Peter Lawrence. Since September 2011, we have conducted 78 interviews. Today, we will be interviewing the internationally famous surgeon, John Wolfe, consultant vascular surgeon at the Department of Vascular Surgery at St. Mary's Hospital in London. Mr. Wolfe, an Englishman, is an honorary member of SVS. Dr. Wolfe, thank you for agreeing to this interview.
Thank you for inviting me.
Let's start from the beginning. Tell us where you were born, when and where.
I was born in 1947, and I was born in Cardiff. I'm not Welsh, and so it's something I keep very quiet about. And when I was 2, I moved to London, where my father got an appointment as a surgeon in London, and so we moved to London in 1949, and I spent most of my childhood in London.
So tell us a bit about your parents.
My father was a surgeon, and his father was a general practitioner who started in medicine late because he was on the clipper ships going around to San Francisco, and that's how he earned the money, with a bit of support from his brother, to go to medical school. Hence my father also went to medical school, and then me. I'm afraid to say none of my children have decided to do medicine. That's probably my influence. And my mother, he met my mother in the war, in the Second World War, and they met in Plymouth during the Blitz, and then they got married 2 years after the war finished.
Tell me about the influence that they had on you growing up.
Oh, enormous. I think I had an enormous respect for what my father did and for the way he did it. And I think if you've got a surgeon as a father, you either decide you're definitely not going to do it, or it inspires you to do the same sort of thing. And I saw all the wonderful things that surgery and medicine could offer, rather than the bad side of it, which is the fact that he was always away at weekends when you just were going off for a nice day out or something. So that influenced me. And my mother, as a result of him doing the surgery, was very much the bedrock of the family, and she was always there for all of us. I've got 3 brothers and sisters, and so she was always there, and that provided a very strong, secure, and happy family background.
Now let's talk about your education. Since the educational system is a bit different in England, please guide us through your education, particularly your undergraduate medical school and surgical training.
Right. Well, I went to, in England, what's called a public school, which is a private school.
Right.
And that was a boarding school in the south of England, where I played a lot of rugby and probably didn't do as much work as I should have done. And the only reason I got into medical school, which would be quite shocking for people nowadays, was because my father knew the dean of the medical school, and with my rather ropey A-level results, the equivalent of graduation, he managed to say, okay, well, we'll give him a chance and let me into medical school. And I went to St. Thomas's Hospital, where I spent 5 years doing medical training at St. Thomas's, which is very, very clinically based, and particularly at St Thomas's, it was renowned for some very good clinicians in medicine, surgery and everything else, but it was a very clinically based training, so you came out with the firm intention that you had to make a diagnosis from history and examination, and only when you'd virtually made the diagnosis did you go to investigation.
Now, your surgical training, was that at St. Thomas as well?
Yes, it started, well, I mean, in England, certainly in those days, you tended to move around a bit. And I went to, I did my house jobs at St Thomas's, which is the internship, and I worked with Frank Cockett. That was the first job I did, which was a great start.
Right.
And then I went to St James's Balham, where Tanner was doing his gastrectomies and Tanner slides, and I did 6 months there. And then I went to work with Belsey in Bristol, and did esophagectomies and these TOFs down there. So it was a wonderful, wonderful start to a surgical career, seeing these really brilliant surgeons. Then I did a very early in my career, as it would be seen by trainees now, I was a registrar in Salisbury, where I was the most senior person on call except for a consultant at home. And you just had to deal with everything that came through the door, and I was there for 18 months before going back to St Thomas's, where I did a 2-year job as a registrar, as we called it, and then research with John Kinmonth, and then you're a senior registrar, and finally you become a consultant. And before you get a senior registrar job, which was a huge bottleneck in those days, I'd done my research, I'd done a thesis on lymphedema. There were no jobs coming up, and my boss at the time, Crawford Jameson, said, "John, would you like to go to Boston?" And I said, "Well, I mean, yes, that sounds fantastic." And he says, "Well, can you leave in 3 weeks' time?" And I had 2 small children and a wife at home, so there had to be a little consultation. And I'm glad to say that my wife, after an immediate telephone conversation, says, "Yes, okay, we can do that." And so I left very soon after that to join John Manick at the Brigham, where I did research for a year, and it was the most spectacular year. And I think it changed my whole perception of what I wanted to do. And I was the research fellow, and the clinical fellow there was Alec Cruz, and we've been lifelong friends.
Wonderful.
Yeah.
Must have been a spectacular year.
It was a very special year. And you know, the friendships and the openness of the American system is something that I really tried to emulate and take back to Britain, because people are just so open and so kind, both in terms of their hospitality, but also in terms of their research. They're always wanting to help each other, and they're optimistic, and they drive forward. It's not this sort of slightly more protective feeling sometimes you get in the atmosphere in England.
Now tell us a little more about your family.
I've got 5 children. I had a divorce, unfortunately, probably because I was not concentrating enough on family and working too hard. That was over 20 years ago, and I've now remarried Dottie, and so I have a stepdaughter from her as well. So there's 6 children, and I've got 7 grandchildren now.
Wow.
So that's very nice, and they're all very close, and I see a lot of them. Luckily, they're all still in England.
Now, yesterday we talked a bit about your hobbies. Tell us a little bit about that.
When I was younger, I played a lot of rugby. I've always enjoyed skiing. I've done a lot of sailing, and I continue to love sailing. And I've now got a part ownership of a boat, and we sail around, the Channel and Ireland and Brittany. And I do some racing in cows, which is nice. And I've also sailed the Atlantic, which I did a few years ago.
Really?
And across the Southern Ocean to Antarctica.
Well, you're a serious sailor then.
Yeah, well, it's good fun. I love the sailing. And since I've now stopped doing clinical work, and I've taken up sculpture, which is yeah, it's very involving, and it's just, you develop the same commitment as you do to operations.
And you've done a bit of climbing.
Well, sort of climbing. I'm not a climber. I'm not somebody who can get up a proper mountain, but I've put crampons on and I've scrambled and I've got up snowy surfaces, but I'm not a proper climber.
Tell us who you would consider to be your mentors. You mentioned some very famous names in your education.
I've been extremely lucky. I mean, the first person, as I say, I worked for was Frank Cockett. And everybody knows about his huge contribution to venous disease, and he was the most wonderful person to support you. And in those days, he was doing aortas with interrupted silk.
Wow!
So that was the way I did the aortas in those days. And then I worked for some very less well-known but wonderful surgeons. I also worked for Frank Belsey in Bristol, but obviously not a vascular surgeon. When I came back to Thomas's, I was working with Norman Browse, who is one of the best technical surgeons I've ever seen. And John Kinmonth, of course, had an international knowledge of lymphedema, and I did my thesis with him. Crawford Jameson, who was another very good surgeon and a wonderful man to work with, a very friendly, supportive person to work with. And then, of course, John Manick, who had enormous influence on me, because before I came to the Brigham, I very much saw myself as working in a district hospital doing general surgery and a bit of doing vascular surgery. But I really sort of changed my attitude during my year in Boston. And when I got back to England, I was quite keen to work on a major vascular unit and focus entirely on vascular surgery.
Well, you had some tremendous mentors.
Yeah, yes. I was very, very lucky.
We had dinner with John Manick the other night.
Yeah, right.
He's doing fine.
Yes, I saw it. I've seen him at the meeting, yeah.
Now, about your awards and honors, you've been awarded the Hunterian Professor of the Royal College of Surgeons, the Monaghan Fellow of the Association of Surgeons of Great Britain and Ireland, President of the European Board of Surgery, Chairman of Education and the Training Committee of the European Society of Vascular Surgeons. Which of these has been most meaningful to you, John?
Oh, I think that's very hard. I think at a different stage of your career. I mean, I think getting the Hunterian professorship, that's something you get in those days most from your work in your thesis, and that was I was a senior registrar. I wasn't a senior registrar. I needed a senior registrar job. I wrote a thesis on lymphedema, and that gave me the Hunterian professorship, which obviously gave me an enormous opportunity when I was in interviews. It also gave me the opportunity because Bob Rutherford came up to me at the meeting here, and as a result of the fact that not that many people are interested in lymphedema, he got me to be the associate editor in his textbook when I wasn't even a consultant on the lymphedema section, which was again, a huge opportunity. And then I think later on, if you're made the president of a society, the European Society and the British Society, then that is it's a wonderful privilege, but it's also a wonderful opportunity to really try and mold things a little bit in the way you see things going forward.
You have a large, extensive list of publications, over 300 peer-reviewed articles, 100 book chapters. How has all your success happened? Why you, do you think?
I think a lot of other people helping write the papers, for one thing. I think it depends how focused you are, and I think if you're really interested in your subject, and I think most surgeons are really interested, and then you have the opportunity to be inspired by people like John Manick and Browse and people like that, then you learn how to critically evaluate and ask the questions. And then you need to build people around you who are prepared to work with you so that, it's not just a one-man band. And if you can achieve that, then things start to happen. And, there's lots of people writing that amount of work as well as me.
Now let me ask you, a somewhat unusual question, but I think it goes to something that's quite important for surgeons and perhaps all physicians, but particularly surgeons. All of us as human beings have been discouraged at one point or another. Have you ever been disappointed, discouraged? And how have you managed that? How have you gone forward from that?
Yeah, I think I'd been a consultant for maybe 5 years when my wife asked for a divorce. And that was obviously a cataclysmic event with young children. And that, it'd been a happy marriage. I mean, that was, I think, because I was working too hard, I was focusing too much on work, I was working at weekends as well as during the day and in the evenings, and it was just too much. And it was very difficult at the time, but I think what I learned from that is that you have to apportion your time a little more carefully so that you keep each aspect of your life running parallel. And I think I'm not the only surgeon who's suffered from that problem because of just focusing too much on their job. And I think with my second marriage, the balance has been much better.
So you did take away
Yeah, definitely. I mean, I think you...
some knowledge from that event.
I think that, yes, I think so. And I think the other area where you could say I was disappointed or self-critical, if you're doing thoracoabdominal aneurysms, which I did a lot of, and I spent a lot of time doing that sort of surgery, you have a lot of failures.
Yes.
And you're always a little bit on a knife edge as to whether you are doing the operation too much or not. And that at times can be difficult because you have a good run and it's all okay. You have a couple of bad problems or paraplegia, and you start to wonder whether this is something that you should be putting patients through. And I think if you're doing stuff like thoracoabdominal aneurysms, would be the experience of most surgeons doing that sort of surgery.
Right.
And you do have to look very carefully and critically as to why you're doing the operation. Are you really doing this for the patient's benefit? And it's nothing to do with your own ego, your own desire to build a series of thoracoabdominal aneurysms. And that's something you just have to deal with in your own conscience.
Right, you're so right. Let's talk for a moment about your research interests, John. I know you have many research interests, particularly about vascular training. It is a great worry among vascular surgeons in the United States that endovascular treatment will prevent adequate training of our vascular residents and fellows in open vascular surgery. Do you think simulators could play a role to help us substitute here for open vascular training?
Not substitute, but as an adjunct, they're very important, and I think they should be universal. And it's an area that I've spent a lot of time on. Throughout my career, I've been doing cadaveric workshops, simulator workshops, and trying to help people to learn the technical aspects of surgery outside the operating theatre,
right?
Which I think is very important. And I see no reason why you cannot use simulators to the various highest and most complex levels of surgery in terms of the techniques you have to learn. And I think there are a lot of surgeons, and I hear it all the time at meetings, and I hear it all the time when I'm giving talks on simulators, that they believe simulators are something that you can use in the early years of training but become valueless as you get better, because simulators can't simulate complex things. But all you have to do is to make the situation awkward. So in order to do the anastomosis, you're down in a corner on the simulator, that sort of thing. And you can then show people how, by changing their positions, they can do it much better. And they also begin to understand that although they can do an easy one, they're actually not very good at doing the complex one. And by trying to get everybody to buy into this, so you get the senior trainees to show the junior trainees, and then by teaching they realize where there are holes in their own technique. I think it's fundamentally important, and I think it should be, there's a lot of, as you know, there's a lot of research now on this and showing how you can show that people improve over a course. You can show that people improve over time if they're using simulators, and it should be very much part of the regular surgical training program, in my view, for the reasons that you state. I mean, the number of open aortic aneurysms are very small now compared with the past, and if it is open, almost by definition, there's no neck, or there's a very difficult neck, because otherwise it would be done by EVAR. Right. And then it's more difficult for the trainee to learn the basic techniques of doing an aortic neck. Right. When I was younger, you could take a very junior trainee through an easy aortic neck. They could be relatively junior, and you could take them through it very safely, and it gave them confidence.
Right. Visceral hybrid procedures for thoracoabdominal aneurysms. Do you think this will replace open repair?
Well, I think the majority of surgeons feel that it was a sort of bit of a blind alley. I don't think that's the case. I think my view is very straightforward in thoracoabdominal aneurysms, and I'm not talking about type 4s, because I think type 4s are a different category. They're much more straightforward, and in my view, you can do them through the abdomen. I'm talking about the type 2s, type 3s, and where arches are involved. And under those circumstances, I do not believe that anybody should have a thoracoabdominal aneurysm repair unless they're in a department that is capable and experienced in endovascular and capable and experienced in open surgery. And if you have those two skills, then in my view, as at St Mary's, we found that there were people who were not suitable for endovascular. The aneurysm simply wasn't suitable for it. And the risks of an open surgery, a purely open surgery approach on left heart bypass in a type 2 or a type 3 or usually type 2, the risks were too high. And we have found that by using the hybrid approach, a transabdominal hybrid approach, we could reduce the risk in those type of patients. And our elective mortality for hybrid repair of type 2s and 3s is 7% in that group of patients, which is not great, but it's not as bad as you might think. So I think there is a real role for that. But it has its own technical skills, and I think it got a bad name, the operation, because people thought that they knew how to do a visceral hybrid because they knew where the arteries were, and they knew how to do an anastomosis, and they hadn't learned the nuances of the operation, as a result of which people, they got some bad results and they decided, I'm not going to do that anymore.
When SVS and ISCBs merged, do you think this was harmful to international exchange?
Not at all. I think vascular surgery is a relatively small specialty, and that's something that we have to recognize. And because it's a small specialty, it's important that, in my view, that continents are represented by one strong body. So in the United States, the SVS, in Europe, the ESVS, and so on. And those bodies need to be strong, and you do not want different bodies trying to represent the same group of surgeons. So I think these mergers are very helpful. And as you might know, I'm very involved with the World Federation of Vascular Societies, which is not in any way separate. It's meant to be a global umbrella for certain aspects that can be, where there is a global element to it, where the major societies can work together. And I think that cooperation, that coordination is probably very important for vascular surgery, with all the problems that there are in terms of delivery, but also in terms of who does what with the radiologists and the cardiologists and so on.
Yeah, one question that may be a little bit out of the box, but perhaps you could share some ideas that from a far view, our medical care system has become a political football, as you know, from watching from afar perhaps. Anytime our medical expenses exceed 10% of GDP throughout the world, that system gradually becomes assigned to socialized medicine. Our GDP exceeded 10% 10, 15, 20 years ago, and it's continued to accelerate. Now we've gotten Obamacare, and I think we'd all agree that our medical system has become a mess. Do you think there's any way out of this other than a single-payer system, in your view?
That's a very difficult question to answer. I think a long time ago, Ira Rutkow wrote a paper on the operations done in, I think it was Canada, the United States, and Britain, and he used carotid endarterectomy and one other one. And then the number of surgeons in those countries, Canada, United States, and Britain, and then the time frame was a decade, and the number of operations going up and the number of surgeons going up. And what was very interesting is that you could superimpose one curve on the other curve directly. So in other words, I think the answer, in terms of also what Peter Lawrence was saying today, is that in order to have the right amount of operations, you need the right number of surgeons, to have the right amount of care, you need the right amount of clinicians. And that is very difficult to deal with. And there is no doubt that at one stage in Britain, the number of operations being done on, for instance, like carotids, was affected by the fact that the surgeons were very, very busy, and therefore maybe they were finding reasons not to operate, whereas in the United States there was the opposite incentive.
Correct.
Where they were wanting reasons to operate because it was a financially remunerated system.
Correct.
And to get the balance is very hard. I'm very supportive of a welfare system. I think the NHS as a system is really the sort of system I like to see, because the bottom line is that if you've got a problem, you get treated. And there's all the negative stories about the waiting list and so on. That's a matter of balance. But in terms of the policy of the system, the principles of the system, I think it's a very good system. The best in the States is better than anywhere else.
Right.
But there are areas in the States, as we all know, where the service is not what it might be.
Right.
And that's a pity in a country that is so well off.
Right. Jimmy?
Well, John, it's good to see you again.
Yeah. And you, Jimmy?
We know each other for a long time, so
Yeah.
it's very special to be able to ask you some questions. Are you satisfied with the exchange between United States and United Kingdom?
Yeah, I think it's always been very fruitful. And as I say, my year in the States completely transformed my approach to my career. And you spent some time at St Mary's, so hopefully that had a good effect on your career. I don't know.
It changed vascular surgery.
Changed my career.
But I think it's a great pity if things become too isolated wherever they are. And I think one of the things that the European Society has done in Europe is to bring on board, for example, the German-speaking bloc in Europe, where a lot of material was lost to the rest of us. We didn't realize what they were doing. We didn't realize what was happening. And now that they're much more involved and they're prepared to speak English, which is, I know, sort of slightly, it's a bit unfair on those who it's not their first language, but I mean, that has it's improved communication and understanding on how different people deal with difficult problems.
Yeah. Good point.
With the internet, you think that could be used to improve the exchange?
Yeah, definitely. I 100% believe that. Having said that, I think the idea that you can replace person-to-person discussion, even if it's in the bar, with exchanges across an internet Skype-type communication, they're not the same. And there's a big difference between talking to somebody gently at a meeting and just gently talking to people around the room and having a conference on Skype. But it's a very useful tool to have as well.
You mentioned about Alec Cruz.
Yeah.
I'm sorry to inform you he's not doing well.
No, I know.
Could you
yeah.
say something about when you were working with him together?
Sure. Yeah. Well, Alec was the clinical fellow to John Manick, and he had a great interest in, he and John Manick had an interest in graft stenosis, which I sort of took back to England and continued with. And he and his then wife Monica, as you know, who died subsequently, were incredibly warm and welcoming, so that I came across initially, and they started to look after me straight from the beginning of arriving at the Brigham. And throughout the year we had a wonderful time, and I've seen Alec a lot since then, both as a friend but also professionally. It's you know, continuing to have an interest in graft stenosis and all the seminal work that he's done on graft stenosis and the biology has been wonderful. And I've always enjoyed our professional discussions as well as having him as a friend. And he's the godfather to one of my daughters. So
that's right.
And we went over and saw him in November. So that was very nice.
I must tell him that.
Yeah, he's a very to have a surgeon who is so totally dedicated to the research, I think is not unique. That would be a silly thing to say, but it's certainly very special.
Now, in looking at the history of vascular surgery, we always talk about the first cardiac surgery at St. Mary Hospital.
Yeah.
I know
Unless you're DeBakey.
I know you have a meeting couple years ago.
Yes.
A one-day meeting. You invite Felix Iscard there.
Yeah.
And we visit the whole case. Can you tell us something about that meeting?
Well, I can tell you something about the first carotid, because Felix was a research fellow at the Brigham, and he was doing animal studies on greyhounds, I think, taking out the carotid bifurcation and replacing it. And so he went back as a very junior consultant or senior lecturer under Charles Robb. And so when Charles Robb, they were considering doing the carotid surgery, had become a possible treatment for preventing stroke. Rather than doing it himself, Charles Robb had the generosity to get Felix to do it, because he was the one who'd done the operation on greyhounds, but not on humans. And as we subsequently know, it was a replacement of the carotid artery rather than a carotid endarterectomy, which is not what he did. But the point was, it was the first attempt to prevent stroke by doing carotid surgery. And in those days, they were doing it under deep hypothermia, so the whole thing took all day. I think it was, those pioneers were very, very brave surgeons to take on the sort of things that they had to take on. But it was a landmark, and people started doing the operation from then on.
I was told the case was discussed with DeBakey and Jack Wiley before the surgery. Was that true?
That I don't know, but I think I'm told that Jack Wiley is in the picture of the operation, but that may not be true.
That was not the case.
No.
But there's a paper by Brownie Wheeler.
Right.
Described the case and said that
it was discussed.
The case was discussed at one time with DeBakey and Jack Wiley.
Right. Well, I didn't know that. Very sensible.
Now, the author on the paper is Pickering.
Yeah.
Charlie Robb, Felix Iscard.
Yeah.
The three. Who make the decision to go ahead to the surgery?
I can't answer that, but Charles Robb was the head of department. So it may have been, but they would have, I mean, again, with the British system, all those patients come through the physicians. So the patient would have had to been referred by Pickering to have been submitted to the operation in the first place. And one of the problems in Britain for years after that was that the neurologist didn't believe that the operation was safe enough, so that there were very few surgeons getting experience in carotid endarterectomy. But I think it was, in the early days, a dangerous operation, and the physicians wouldn't refer them.
And later on, it turned out the Baker said that he did that a year before that.
Well, he should have written it up, shouldn't he?
And also, the surgery was not the routine endarterectomy, it was a transection.
Exactly.
And then we
reimplant it again. Yeah, that's right. Yes.
It's always very interesting
Yeah,
because
the details.
they always talk about the first cardiac surgery.
Yeah.
What feeling had to say when you had the meeting?
He didn't go into those details very much, and I mean he was there as an honoured guest rather than having to speak, and so I think he didn't actually speak. He was we were all just honouring him because it was his 80th birthday at that stage, I think.
That's a very interesting case.
Yeah.
The patient had 30 episodes of TIA.
Yeah.
30.
Yeah.
That's a lot.
It certainly is. Lucky not to have stroked.
You listened to the presidential address this morning?
Yeah, I thought it was
Do you have any comment?
I thought it was wonderful that he addressed the issue so clearly, head on, and without being melodramatic about it, but very clear about the data. And it is an issue. It is a very serious issue now. I think that for years in vascular surgery, we didn't get enough support, if you like, from companies, but there wasn't that industrial pressure that there is now. And I think the relationship with industry is more complex now because they can provide all these instruments for office-based treatment, and there is pressure from industry to intervene. There's, as we heard, there's the pressure of remuneration to intervene, and the overarching audit of that intervention appears still to be lacking. And I think that's the answer, is that there has to be good audit of what's going on. And if you have good audit, and you've got good audit in lots of areas, and if you have good audit, then it will come down to the fact that why is somebody who has no training in vascular disease being allowed to do this? Why are they being remunerated for something for which they have not been trained? And so I think that if there's stronger audit, then that is going to improve the position of vascular surgeons, because we have been trained in the full gamut of management and treatment and investigation of vascular disease. And I think that's what we have to state very clearly. And I think government, whether it's the United States or Britain or anywhere else, they understand that. And they would be horrified if they thought that people were being submitted to procedures by people who had no training in the underlying pathology or understanding of what they were doing. It doesn't make any sense. And I think that, I hope that's going to happen. I mean, we've started auditing very carefully the results of individual surgeons in Britain. And if people go outside on the funnel plot, then the society will go and talk to them, and the chief executive of that surgeon gets notified that for that operation they are outside the parameters that we believe are appropriate.
What is your opinion on endovascular surgery for aneurysm? You think eventually you're going to be all endo? What's your take on that?
Well, with the current technology, definitely not. Because the current technology does not allow all aneurysms to be treated endovascularly, and I think the reason that the results in the randomized trials are similar to open is not because the two procedures are similar in any way. It's because people are pushing the envelope, as people now say, and they're trying to do EVARs in patients that maybe they shouldn't be doing them on, as a result of which they're getting bad results in that group of patients. My own hunch is that if EVARs were only done on the easy aneurysms with long necks, then the results would be entirely different to open surgery. It would be much better. And I think there will always be failures of EVAR, and therefore there will always be a need for open surgery. And I think it would be very wrong for vascular surgeons to believe that they can treat everything in an endovascular way. I mean, I think what will happen is that technology will advance, and that probably for straightforward aneurysms, we may end up in a situation where there are virtually no open repairs of straightforward aneurysms. Once it becomes more complex, then you're balancing the risks of cannulating a diseased renal artery with doing a bypass onto a renal artery by a surgeon who's been appropriately trained. And we know that getting those appropriately trained surgeons is getting more difficult, because, and that's the circular discussion, and it's very important that we don't lose sight of the fact that open surgery is a necessary part of vascular surgery. And I tell the young trainees that in the future, the people who have got the tertiary referral practice will not be the people who do the endovascular, which is currently the case, I would have said. It will be the people that can get the patient out of trouble because they've had an endovascular procedure, and then it has all gone pear-shaped, and then you have to have a very complex open procedure to resolve the situation. So I think that the two work very much in balance, and endovascular will become, there'll be even more endovascular, but there'll be areas, in my view, like distal bypass, where distal bypass should come back a bit, because I think there's a lot of unnecessary and rather inappropriate endovascular treatment of distal arteries.
Well, Roger interviewed Tim Schuller yesterday.
Right.
He made a statement. Maybe, Roger, you can tell him what Tim said.
Much to my surprise, Dr. Tudor said that he felt that any younger patient, this is relatively speaking, younger patient,
Yeah.
with low risk factors and a reasonable neck should have an open repair. Well, I almost fell out of the chair because I thought he would certainly say that most patients, if possible, should have an endovascular repair because of low risk, low postoperative morbidity, and so forth and so on. But his rationale was that open repair carried such known longevity of a good long-term outcome. Would you agree with that?
Yes, but then the endovascular evangelists would
Right.
say I'm a Neanderthal, and I would say
Right.
that, wouldn't I?
Right.
But I mean, the way I look at it is, if I think if you're in your 60s, if I had an aneurysm now, I would be very prepared to have an open repair. Once you're in your late 70s, then you've got to look much more carefully at the immediate risks of the operation.
Right.
And you always have to balance it. But,
Right.
but again, I make the same points I made about thoracoabdominal aneurysms. You need to be in a department where the department is equally happy doing open or endovascular
Right.
repair. It is
Right.
immaterial to them which they choose. And they work with the specialists, maybe be different people, and you work together, and then you make a decision. And I think if you do that, there will be a number of the current endovascular repairs that in a department like that would not be performed. They would say, this is safer and better done open. And indeed at Mary's, there are a number of infrarenal aneurysms that are done open for just that reason.
I was so taken by what he had to say. It made so much sense.
Yeah, yeah.
I was so surprised. What he was really saying was that if they have low risk factors and are youngish, should be done in an open fashion.
Yeah, and then you know you should be able to.
Wow.
That's it. You're home safe after that. You
Right.
don't have to worry about it anymore.
Right. No more endo-leak, no more serial follow-up. Done.
Yeah. But having said that, I mean, Tim Shooter's advances in making us think seriously about
Right.
complex
Right.
endovascular repair
Right.
was a landmark
Open
change
the door.
yeah,
Open the door.
Absolutely. Yeah.
Jimmy?
Well, you have anything you want to bring up for us?
I don't think so.
We-
You've asked
we-
me a lot of questions.
Well, we have a last question for you that
Yeah.
we always ask at the end of our interview, and that is, do you have advice for the young vascular surgeon?
I think any young vascular surgeon needs to make sure that they are fully trained in open and endovascular surgery and they feel skill in both areas. They need to have the basic fundamental skills in both areas, and it would be wrong to go through thinking they can get away with one or the other. That's one thing. I think our generation, we felt that we were doing a lot of emergency and urgent surgery, and therefore it took over our lives. And in Britain now, 70% of people coming out of medical school are women. And that means that a lot of those people have got a different life perspective. They've got other things that they have to consider. However much we say it should be the same if you're a man or woman, at the moment society simply doesn't run like that yet. And so I think vascular surgery offers a huge opportunity for women who want to also in the parallel maybe have a family, because they can be doing the emergency rosters, the major arterial surgery, but then they can also move towards the laboratory side of it, the venous side of it, the importance of the diabetic foot, the leg ulcers, all the other medical things that we manage as so-called vascular surgeons, but actually we're vascular specialists. And I think that gives them a huge opportunity to sort of mix and match what they do within the specialty. Whereas in other specialties, I mean, let's say cardiac surgery, that would be out of the question. You're either doing it or you're not doing it. So I encourage the women who want to be surgeons that vascular surgery actually does provide an opportunity for that lateral movement. But if you're going to be a vascular surgeon, you've got to be prepared for it to take over your life, that's for certain.
John, thank you for this interview.
Okay.
We've really enjoyed it.
John,
Thank you so much.
for coming.